से स्लाइड कैसे नीचे करना है? Okay. I am going to talk to you about the hypothyroidism, subclinical hypothyroidism, when to treat. Just to understand, there is a thyroid gland. Thyroid gland produces two hormones, T3 and T4. When they are produced less than the normal amount, TSH, which is secreted from the pituitary, it increases in amount. So high TSH, low T3, T4 is hypothyroidism. And what is subclinical hypothyroidism? Subclinical hypothyroidism means T3, T4 are normal limits, but TSH is elevated. It is a biochemical diagnosis. Patient is having minimal symptoms. Only thing is TSH is elevated, T3, T4 are normal. And these patients do come to you, about 3 to 5% of the patient do come to you. And what to do in these patients? Subclinical hypothyroidism has been divided into two parts, mild, severe. Mild means TSH is between 5 to 10. Severe means more severe, means TSH between 5 to 10. But T3, T4 are normal. What are the causes of subclinical hypothyroidism? Same as are the hypothyroidism. Autoimmune diseases are the most common, then is the iodine deficiency. Before I take up this, what should you do? I would like to discuss 3 or 4 cases, just within 1 or 2 minutes each case. 28 years old pregnant lady has come to you, pregnant, with TSH elevated, T3, T4 normal, anti-TPO high. What should you do? 8 weeks pregnancy. Patient पूछता है, should I continue with the pregnancy? What are the problems anticipated? What are the TSH should I maintain? Is the treatment required? Let us see. Pregnancy at 8 weeks with subclinical hypothyroidism. This is the diagnosis. We should allow her to continue the pregnancy. We should not act like a god that you should terminate the pregnancy. Maintain the TSH within the trimester specific range. That is less than 2.5 in the first trimester and less than 3 in the second and third trimester. Start with the thyroxine. Absolute indication. How the subclinical hypothyroidism affects the pregnancy? It has got adverse effect on the pregnancy loss. It can lead to premature delivery, or it can have the adverse outcome on the offspring, that is IQ might be low. So, a patient who is pregnant comes to you with elevated TSH, must treat her. And target TSH less than 2.5 in first trimester and less than 3 in second and third trimester. Second, a lady who is planning to get pregnant, TSH is mildly elevated, 6.6, anti-TPO are high, T3, T4 are normal. Should the treatment be started? Diagnosis subclinical hypothyroidism with TPO positive. Yes, one should start with the treatment. Why? Pregnant woman, subclinical hypothyroidism, desiring to get pregnant. T4 has got half-life of 1 week. If you start with the thyroxine, it would take 4 half-lives for the effect to come. So, 1 month. And if the patient becomes pregnant, 1 month he would have to spend his pregnancy with suboptimal control of thyroid. So you should start with the thyroxine when the patient comes to you with elevated TSH and if she wants to become pregnant. Target TSH is less than 2.5. So any patient who wants to get pregnant, TSH elevated, start with thyroxine and keep the TSH less than 2.5. Third case, 16 years old female comes to you with menorrhagia, TSH is elevated, T3, T4 are normal. Should you start with the treatment? Here the diagnosis is subclinical hypothyroidism with menorrhagia. Menorrhagia can be the earliest manifestation of subclinical hypothyroidism. This patient should be started on thyroxine and reviewed after 2 months. And it has been seen, if you just give the thyroxine, patient might be cured of the problem, and the periods would become normal, and she would never have the recurrent problem of thyroid, periods problem. So first we have discussed pregnant lady with subclinical hypothyroidism, then person wants to become pregnant. Third, young girl with menorrhagia with elevated TSH. Now fourth case, 29 years old female comes to you with subclinical hypothyroidism, repeated after 3 months, again TSH is elevated, T3, T4 are normal, but here patient is on oral contraceptives, she doesn't want to become pregnant. She has got family history of hyperthyroidism, thyroid is mildly enlarged. What should you do? Subclinical hypothyroidism, in her case, I would not like to start the treatment for thyroxine. Repeat her TSH after 2 months. If the TSH is less than 5, anti-TPO are normal, just mild goiter, I might not like to start with the treatment. If TSH is between 5 to 10, might be I would start with the treatment within her case. Or might be, if more than 10, I would like to start. Between 5 to 10, I would not like to start the treatment at all. And in further testing, 1/3 of the cases TSH becomes normal on repeating the TSH after 2 months. This is a common query which comes to me. Patient is posted for surgery. TSH is elevated. T3, T4 are normal. Patient is already on thyroxine. TSH is less than 10. Should you take up the patient for surgery? Yes. Here it is. Patient is posted for bypass, already on thyroxine and atorvastatin. Can the patient undergo surgery? Thyroid hormone does affect the cardiovascular system. It leads to impaired diastolic function at rest, impaired systolic function on effort, enhanced risk of atherosclerosis and myocardial infarction. Here, given the treatment, it is more beneficial than the harmful effects. And in symptomatic patient, one should treat. And ideally, patient should be given thyroxine at least 48 hours before surgery. Preoperative evaluation of thyroid function is recommended, and it helps in better outcome of the patient. And furthermore, if the TSH is mildly elevated up to 15, you can take up the patient for surgery without any high risk, without any complication. If TSH is more than 15, there are high risk for bleeding, infection, hyponatremia, and delayed recovery from anesthesia. Even then, emergency surgery is not contraindicated. Elective surgery you might like to postpone if TSH is more than 15. In thyrotoxicosis, one should not take up the surgery unless it is life-saving surgery. Furthermore, a patient comes to you with goiter with mild elevation in TSH. She is symptomatic just because of goiter. Should the treatment be started? Medical treatment, early stage of goiter, soft goiter, TSH is elevated, it helps in reducing the size, but to a limited extent. If the patient is having large goiter, there is dysphagia, dysphonia, the surgery is recommended, especially if you are suspecting it to be malignancy and medical treatment is not practical. Radioiodine, if the patient is thyrotoxic, subclinical or clinically toxic, you must give radioiodine. It reduces the size of thyroid by 30%, non-invasive. So, giving the thyroxine as subclinical hypothyroid, it normalizes the thyroid, patient feels better. But if the compressive symptoms are there, patient should undergo the surgery. So, if a patient comes to you with subclinical hypothyroidism, TSH mildly elevated, T3, T4, you should repeat the thyroid profile after 2 months, get anti-TPO antibodies, first confirm that is persistent hypothyroidism, not transient. Patient can have transient elevated in TSH, especially if the patient is recovering from some non-thyroidal illness, and it becomes normal after 2 months. But if TSH is elevated after 1 to 2 months, get anti-TPO antibodies. If anti-TPO antibodies are positive, it leads to 60% chances of patient would develop hypothyroidism in next 10 years. If anti-TPO are negative, their chances are reduced to 25%. So presence of anti-TPO antibodies gives you an edge that your patient should be treated. If anti-TPO antibodies are not available or you want to get the result immediately, get an ultrasound, giving an hypoechoic inhomogeneous pattern, it indicates that autoimmunity. You might like to start the like to start with the thyroxine. Ultimately, it comes from the aspiration biopsy, but this is not recommended in clinical setup unless you're suspecting it to be malignancy. Few of the patient might be having some symptoms of hypothyroidism like dry skin, poor memory, weaker muscle, poor muscle cramps, more feeling cold, deeper and hoarse voice, puffier eyes and constipation. But they are uncommon and these symptoms might improve with starting with the thyroxine. Screening. All ATA recommends that all the people above the age of 35 should be screened for thyroid function test, with the TSH at least. Pregnant ladies, they say they should give the special consideration, but in our setup, it might not be feasible because of the economic factors. So what are the people who are high risk in which you should screen for them for thyroid dysfunction? Female sex, advancing age, patient who is having other autoimmune disorders like type 1 diabetes, celiac disease. There you must get the TSH. Patient with Down syndrome, they are high risk to develop the hypothyroidism. Patient who is having family history of thyroid disease, goiter or previous hyperthyroidism, must screen for with TSH. Or a patient who has received the external beam radiation to head and neck area. Treatment is oral thyroxine. Dose I would like with 25 microgram if TSH is less than 10 or with 50 microgram if TSH is more than 10. In elderly and a patient is having coronary artery disease, I might like to give only 12.5 microgram starting dose and then titrate the dose according to TSH. Repeat the TSH after 2 months and adjust the dose. Target, keep the TSH, young age, less than 50, between 0.5 to 2.5, above 50, between 2.5 to 4.5. How you follow up these patients? If the patient is untreated, you are just repeat the T3, T4, TSH after 2 months. If it has normalized, not to repeat it further. Let the patient कि आपको मेरे पास आने की जरूरत नहीं है. If you have started with the treatment, then TSH should be monitored at least annually. This is the second last slide. If TSH is how you treatment algorithm. If TSH is more than 10, start with the treatment. If the patient TSH is less than 10, up to 5 to 9, if the patient is having symptoms or goiter is there or antibodies are positive, then you start with the treatment. If no goiter, no symptom, anti-TPO are negative, you might like to wait. And treatment should be withheld if the patient is more than 70 years of age. Target TSH should be within the normal limit. Contraindication, just if there is a hypersensitivity to any of the component. Adverse drug reaction, rare. Benign intracranial hypertension in children, and if you overtreat the patient, TSH gets suppressed. Patient would lead to osteoporosis and angina and arrhythmias. Thank you. I am really thankful to Dr. Vitull for inviting me and giving me this opportunity. Thanks a lot. Thanks. If any question, yeah. Yes, ma'am. Yes, Dr. Anurag.
The person who's on thyroxine, what might sometimes say 1 year, 5 years, 10 years. Is there a chance that ultimately thyroxine may be weaned off or it will be stopped altogether? कि once एक बार देनी शुरू कर दी सारी जिंदगी लेनी पड़ेगी. See, dermatology is a condition जहाँ पे we cure the patient. Remission relapses. इधर dermatology में ठीक भी होता मरता नहीं. ठीक हो जाता है, मरता तो नहीं है, but फिर relapse हो जाता है. But medicine में चलता ही रहता है, डायबिटीज क्या, थायराइड क्या, बीपी क्या, हर चीज चलती ही रहती है. तो वो पेशेंट जो आगे उसको गाड़ियों पे उठा के मेडिसिन पे करता रहता है. जब शादी के टाइम में ठा दो. So there's a patient of iron
Dr. Anurag has asked a very good question. This is a common question which is asked by every person who comes to the OPD. Sir, I have been started with thyroxine. Is there any cure for the same? So here I tell you, there are some causes not known as transient hypothyroidism or transient thyrotoxicosis. There are some causes which leads to permanent hypothyroidism or permanent disease. Transient, that means the disease is, treatment is required for only 3 to up to 3 months. That is postpartum thyroiditis, subacute thyroiditis, or painless thyroiditis, or patient is recovering from the previous some non-thyroidal illness. Here the treatment is required for few days, or I would say few weeks, and the patient recovers. But common causes of hypothyroidism, I'm talking about hypothyroidism. Hashimoto thyroid disease, if you have diagnosed, you have started with the treatment, patient has come to you with ESH of 30 or 40, it is a progressive disorder. Ultimately, patient has to be on treatment throughout the life. In endocrinology, the person who manifests to have some disease like diabetes or thyroid, 90% of the gland is destroyed, only then the clinical symptoms occur. And you diagnose, mostly if the patient you are diagnosed at the time of symptom, the treatment is required throughout his life. Might be the dose adjustment has to be there, but the treatment has to be throughout the life. But in thyrotoxicosis, yes. Graves' disease, you give the treatment for 1.5 to 2 years, 50% of the patient would not require treatment in their lifetime. Graves' disease, it is reversible. Nodular goiter, you give the radioiodine ablation, patient would recover throughout his life. But hypothyroidism, Hashimoto, patient would require the treatment throughout his life. Yes, ma'am. Would you like to ask?